Hello, everyone. Good evening, and welcome to tonight's presentation on J-Pouch Assessment, Management, and Surveillance, APN-led J-Pouch Clinic. Our presenter is Michele Rubin. I am Irina Nistor, nurse practitioner in gastroenterology. Thank you, Emily, and thank you, Crohn's Colitis Canada, for supporting CANIBD. We'll start by an introduction about CANIBD. CANIBD is a community of practice for nurses across Canada working in the field of inflammatory bowel disease. And our vision is to ensure people of all ages living with inflammatory bowel disease in Canada receive high quality clinical nursing care within a multidisciplinary team. We are associated with the Canadian Association of Gastroenterology Nurses and Associates, also known as CGRN, and we're supported by Crohn's and Colitis Canada. We are committed to improving the quality of care for people living with inflammatory bowel disease in providing mentorship and learning opportunities to inflammatory bowel disease nurses in Canada, creating opportunities for networking and sharing of best practices, developing and adopting nursing guidelines and standards for inflammatory bowel disease nursing in Canada, and elevating the profile of IBD nursing. I would like to remind everyone that you can find more information about CANIBD on the Crohn's and Colitis Canada website. And reminder to everyone that CANIBD offers a IBD nurse fellowship, and we're currently accepting applications for fellows and preceptors. The deadline is on February 15th of 2019. This is an educational and mentoring opportunity for new and early career IBD nurses across Canada, and both fellows and preceptors can receive up to $2,500 to participate. You can participate anywhere in Canada at the Centers of Excellences in Inflammatory Bowel Disease. The application is available on Crohn's and Colitis Canada website. The link is provided here. And if you have any additional questions, we're more than welcome to respond from members of the steering committee. Now, a little bit more about tonight's webinar. It is my great pleasure to introduce Michele Rubin. She is an advanced practice nurse certified as a clinical nurse specialist in inflammatory bowel disease and certified as a gastroenterology nurse with over 40 years of experience in IBD. And she's working at the University of Chicago Medicine in various ranging positions throughout the years in nursing leadership, inflammatory bowel disease research, inflammatory bowel disease clinical nurse specialist. She's also the Associate Director of the IBD Center and Director of Advanced Practice Nursing at the University of Chicago Medicine. She's a known leader and lecturer on inflammatory bowel disease across the U.S. for various organizations, and she's a professional member of the Crohn's and Colitis Foundation and was recently honored with the Distinguished Advocate Award for IBD patients and their families. She is the current second-time chair of the National CCF Nurse and Advanced Practice Provider Committee and a member of the CCF National Scientific Advisory Committee. Thank you, Michele, for providing us with this session tonight. And prior to proceeding, I would like to thank Takeda for the generous support of tonight's webinar, and thank you again, Crohn's and Colitis Canada.
Thank you, Irina. I really want to thank the Crohn's and Colitis Foundation of Canada for inviting me to come and speak. This is very exciting for me, and I think this is a passionate group of patients that I actually follow for life, basically. They're almost like family. I have some patients that I've been following for about 20 years already, so I'm very passionate about this group. So thank you very much for inviting me tonight. So, whoops, had a little quick thing of the mouse here, but here are my objectives for this evening: to understand the steps, indications, contraindications, and complications of the J-pouch, explain how to assess pouch function, discuss good pouch functional result and quality of life expectations, and understand the importance of pouch surveillance in this group of patients. And like I said, I run the APN clinic. I'm the only one that follows these patients at the University of Chicago. So it's a really nice role for an advanced practice provider. So surgery in ulcerative colitis, obviously the primary goal is to be well. You want to alleviate complications, symptoms, and obviously want to restore bowel continuity whenever we can and achieve the best possible quality of life. The decision to have surgery should definitely be a multidisciplinary team decision. And it's a decision that is made with the gastroenterologist, the surgeons involved, the radiologist, the nursing team around them, and most importantly, who is in the center is the patient. Early discussions are important. I think when we talk about surgery and inflammatory bowel disease, surgery should not be the last resort. It should be brought up in the beginning and mentioned that it is a treatment as well. And we don't want to wait until the patient is so sick to then say, okay, now it's time for surgery. But most often when we've gone through different therapies with the patients, sort of like midway or whatever, when you kind of know that we've gotten through and they've kind of failed a few therapies, it's probably time to introduce the surgeon and get them involved and just let them know this is, potentially the options down the road when the time is right. I mean, obviously we can't always have it planned, but whenever we can, definitely want to plan those surgeries ahead of time. Provider team and understanding and empathy. Obviously, we as nurses all know how important that is. And patient education is also extremely key. And as nurses, we are well on top of that aspect. All right, there we go. So these indications are for ulcerative colitis in general, and I just highlighted at the bottom decreased quality of life, because I do not want you to forget that can be an indication from surgery. As a matter of fact, all of this really is about a better quality of life. Now, the contraindications for a J pouch. If they have small bowel or perianal fistula or abscess in the past, those are often indicative of Crohn's disease. So we would not do a J pouch in those patients. We do them in some Crohn's patients that we think just have colonic Crohn's. And so that's why I say they've never had small bowel in the past and they've never had any perianal fistula or abscess. But they have total Crohn's colitis. Sometimes it's an indeterminate nature there and we don't know for sure. We will do a J pouch in those patients, but a huge caveat there is they are possibly at a higher risk of developing Crohn's disease. Distal rectal or anal Crohn's, obviously, or rectal cancer, we would not do it in those patients because, the J pouch is connected down there low in the anal rectal area. Elderly patients, and this, you kind of got to think about and really assess the patients. Usually older patients have a less favorable outcome. But obviously, I think age is relative. We have done them on some 70-year-old patients, and they're a youthful young. They're out, they're moving around, they're working, they're traveling. Can be somewhat different than a patient who is elderly. And I mean, actually, sometimes I feel like there's some young people that are kind of old and aren't going to tolerate going through 3 steps or whatever. But generally, we kind of say it's better for the younger patients going through 3 surgeries, etc. The morbidly obese patient. Now, this is a contraindication in the beginning because you have to remember we're bringing that small bowel down to the anus. And if a patient is obese and there's a lot of fat to go through, sometimes the mesentery will not reach. So these patients, we definitely can have them lose weight. So there's another option, and I'll talk about that a little bit later, of how they eventually, if they will be willing to lose weight, can be a candidate. And so the proctolectomy with the ileoanal J pouch obviously removes the colon and rectum. There's formation of a J pouch. That ileal pouch becomes the neorectum, and it's attached to the anus in either a hand-sewn or a stapled technique. Preserves anal sphincters and the anus, and those sphincters are key because that's your continent. Restores bowel continuity and can be performed in 2 or 3 steps. And in between steps, there is a diverting ileostomy. Here shows how the ileoanal J pouch is formed. You can see that the end of the ileum is brought up and wrapped around on itself, and this here is opened up and becomes the new rectum, and you see over here it is attached down here in the anal area. Your sphincters are on both sides here, and so they are preserved. There's a temporary ileostomy. You see up here we call the loop ileostomy, and that allows diversion of the stool so that the pouch can heal. And here shows the anastomosis. The hand-sewn anastomosis is, you can see where they strip out that mucosal lining, and the pouch is then slipped right down, and it is hand-sewn in the end. Now with this, when they go in there and they hand sew it, it's tedious for the surgeon, but also they kind of put a little more stress on the sphincters in this situation here, versus the stapled technique, which is most common in what they do now, is they leave in 1 to 2 centimeters of rectal mucosa, and then they bring that pouch down and they stitch it up here, which it is above the level of the sphincters. It's also much easier for the surgeon to do because they just go in with a stapler and staple around. So, what's the difference between these? So, the stapled, like I said, is most performed. It's easy procedure to do, but it leaves in 1 to 2 centimeters of rectal mucosa. Now, why is that important? Because in that 1 to 2 centimeters are the sensations of gas, liquid, and so that's the sensation of where they can, there's like liquid or stool coming down, I can squeeze, or if there's gas, they get that sensation. So they have a little better control right away with incontinence of stool. They may have maybe 1 leak just immediately in the post-op period, but then they have pretty good continence. There's also less risk of an anastomotic stricture because that anastomosis is made a little higher up. It is not low at the anal dentate line. So when it's so low there, it strictures down a little easier. The other thing, there can be less tension on the pouch anal anastomosis because you're giving a little 1 to 2 centimeters there extra room, and sometimes that can mean a lot. The other thing, though, to remember is with that 1 to 2 centimeters of rectal mucosa in, they are still at risk for a potential dysplasia or a cancer to develop in that area, or ulcerative colitis, and we call it colitis when it does occur. It's small, but it still is a risk, and therefore that's particularly why those patients need to be surveillanced. Hand-sewn, obviously all the rectal mucosa is gone. It basically eliminates that risk of anusitis or colitis. They avoid the risk of cancer in that anal transition zone. They do have a little higher risk of incontinence, but I can tell you after a couple months, that hand-sewn group totally catches up with the stapled anastomosis. When we've looked at a large study of this, I would say by 6 months to 9 months, if they've had leakage a little bit ongoing there, it is gone by that time. Used mostly in cases who have known dysplasia or a cancer at the time of colectomy. It's been our practice at the University of Chicago that if a patient does have a cancer, we choose to strip it all out and do it hand-sewn so that there is no potential risk. We also tend to use this hand-sewn technique on the primary sclerosing cholangitis patients because that little bit could still be a factor in PSC. And I know that sometimes I'm not even sure they're even teaching hand sewing much out in the medical school anymore, but we're definitely teaching our staff, but it's not as widely taught as it was in the past. When I first started, this just tells you I've been doing this a long time, all of our patients were done hand sewn, and then we went on to the staple technique. So here is the two-step procedure, and this is more for patients who are not at high risk for complications, meaning high risk for developing an infection. And in those patients, we take out the colon, and we then make the J pouch. We attach it down to the anus, and we give them a diverting loop ileostomy for 3 months. And then at 3 months, we would do a dynamic proctography. It's a test to instill barium into this pouch, and it simulates a bowel movement. So not only do we check if there is a leak anywhere, but also that they can empty the pouch out, and it has good contraction ability. So we do that test, and if that is okay, then we close the ileostomy. So we do this for patients that really are not at high risk, and I'll show you talk later here about what those type of patients are. Now here's the three-step proctocolectomy. Here is the first step. We basically take out the entire colon. They have the ileostomy, and you see they have the rectum left in place. And that is like a placeholder for the next step when we do the ileostomy. So at the second step, we remove the rectum. We take the end of the small bowel, we make the J pouch, attach it to the anus, and they have the diverting loop ileostomy. And then the third step is ileostomy closure. And again, here is where we would do the dynamic proctogram just prior to takedown to ensure that it's healed. So that's the three-step process. There's 3 months between each of these steps. However, the first step, obviously, these are sick patients. We want to get the colon out. So we take them to surgery, and then they can come back and we can do the pouch in 3 months. Or if the patient was pretty debilitated, they take longer than 3 months to recover. Or, hey, say family, they need to go back to work for a period of time because they've been so sick. The time period between these two surgeries could go 6 months to a year. And then they come back when time is convenient, and then we do the step 2. And then here it's 3 months between that one. It could be longer, but most people want to get the stoma taken down at that point. So looking back here, whoops, I'm having mouse problems. Here is why we do the colectomy first in these higher risk patients, why we stage it out to 3. So if they've been on high-dose steroids or immunomodulators, if they're immunocompromised in any way and on the biologics, and some of these patients they've been on steroids for a while, they've failed a lot of drugs, they're kind of pretty sick, and they're coming to surgery. So those would be high risk for complications. The obese patient, like I talked about previously, we do the colectomy, and then they can go and lose weight. And they can either try it on their own, but I'll tell you, a lot of times we have to send them to the bariatric, and they may get the sleeve or whatever to lose weight, and then they can come back and we could do the J pouch. Toxic colitis, obviously they are too sick at the time. If somebody has marginal sphincter strength, and we're not so sure, if they've already got incontinence issues, you can do this step and see is it really just because they're so sick. If somebody has indeterminate colitis, you get the colon out, then we can send it to pathology, and maybe we'll get a better read on whether it's a little more Crohn's disease versus ulcerative colitis. It might just give us a little more information. But if it's indeterminate, as I said, we would still go ahead and possibly do the J pouch as long as they've had no small bowel or anal abscess or fistulas. Patient desires to become pregnant. most of our women pretty much are at a stage sometimes where they've already had kids, but when you have young girls, some of them are like, I'm not even at a pregnancy state yet, or, it doesn't bother me. I want to go ahead with it. But if someone really is concerned about the infertility risk, they will take the colon out, they go get pregnant, have their baby, and then come back. I don't see the infertility as much as an issue as I did maybe when we first started, when we weren't doing this laparoscopically. But I think the laparoscopic technique has definitely helped the fertility piece. But there are some individuals that are really certain they want to be sure that there are no issues with infertility, or the males that we will wait until they have kids or whatever. But the other very important piece here is it gives patients a better understanding of what life is like with the stoma, because they really have no idea. And I feel like at this step, they really understand, maybe the stoma is not that bad. And I will tell you, we do have some patients, young and middle-aged, who they get to this step and they have the stoma and they really, this isn't so bad at all. I'm happy with this, and I don't know if I want to go on and have 2 more surgeries. And in those patients, we let them go, and then they can come back and they say, I want to keep the stoma. Then all we do is we have to remove the rectum at some point, because if that is left in, then that can develop a cancer down the road. So we will eventually move that. But surprisingly enough, there are a few that are very happy with the stoma. They've been so sick, not had a quality of life, and they're like, we want to keep the stoma. Now this here is shows a loop ileostomy that is put in before the takedown, and it's the loop ileostomy. We usually put a red rubber catheter around there in surgery, and it's just to hold it there sort of till it substantiates its place there and doesn't fall in, and it's stitched around there, and then they come back a couple weeks later and this is removed. Now, the thing with the loop ileostomy, you can see both barrels. One is from the stomach, and then the other goes down to the pouch, as you can see here. And you also see it kind of is pretty flush with the skin as well. And this ileostomy, the loop, is definitely not like the end ileostomy. The end of the ileum, when it comes out, protrudes out with an end. With a loop, it does not. So these are much more difficult to manage. And so here's some of the key points with the diverting loop, and then you have that retained ileal pouch in there. With the loop stoma, like I said, it is not like an end, and you really have to talk to the patient about that, because they're assuming it's going to look like the first one, and they had really good seal with the appliance and everything, and now they're going to have this stoma that's not going to be nicely round. It's often oval, and it usually is a little more flush with the skin. And so I really tell patients, and I tell the stoma nurses, really talk to the patients about this, because when a patient has gone through and gotten the J pouch, and then later on there's some complication, and we need to remove the pouch and give them a permanent stoma, oh my God, they're like, I don't want this. That stoma was horrible. It was awful. I could never get a seal. And then I have to say, okay, let's talk about this. Which one was it? Well, it was that second one. I said, you're not going to get that back. You're going to get the permanent end one. So that is a key point, because boy, they always remember that loop stoma. The other thing to remember when they have this loop is 20% of the small bowel with that pouch down there is diverted. Now remember, the end, that was the end of the ileum. They had the entire ileum there that their food and water was going through. Now 20% of that's going to be bypassed. So number one risk here that I see is the dehydration. That is the most common risk. So really have to talk to the patient that they really got to focus even harder to get their foods thickened, really focusing in on eating starchy foods. things that are going to, food that's going to soak up the liquid when you drink. And I tell them, and this is the only thing I found that works to get this concept across to them, is think of your system now like a pipe. How it goes in is how it's going to come out. So if all you do is drink, and that's what they think they need to do when they're dehydrated, they're just chasing their tail because it is running right through. There goes their energy and all their nutrients. So I tell them, think of your system like a pipe. Think of food that's going to act like a sponge. You're going to eat that first. Then you're going to drink and sips of water, and the food's going to soak up the water, slows down the transit time through your system, and allows the intestine to pull out the water and the nutrients. And believe me, all these years, that's the simplest concept that I can talk to them about. They can measure, they can do all they want. They still don't seem to get that. The other thing is the use of antidiarrheals like the Imodium or the Lomotil. Also, I would say almost 100% of them need to use that at this stage with the loop. They could also use any fiber preparations as well. The other thing to remember is the rectal discharge. From the diverted, in that first step, remember when you just take out the colon, we left the rectum in, they're going to have a mucus discharge from there. But also with the J pouch, when that is there and diverted, there's going to be a mucus discharge. And they need to understand that because they're thinking, why am I getting something from below when I'm having stool going through and into the ileostomy? So really, you got to remember to talk to them about that because otherwise they kind of freak out like what's going on. Now, from the J pouch, it really should just be mucus. Usually do not see blood, and it's not urgent. So they should just see maybe a passage of that mucus once a day, every other day. It can vary. Now, diversion proctitis can occur in that retained J pouch. And obviously what that is, it's inflammation that forms in there due to diversion. And they may start having, instead of one discharge a day or so, they start having 3 or 4. They're getting the urgency. Usually don't see the blood in the J pouch, but if in the retained rectum, they could see blood because that diversion proctitis is probably the ulcerative colitis in the rectum. In the J pouch, it's just a diversion and inflammation can form. And we just treat that with topical therapy, either a foam, enema, or suppository. Usually, with the stool being diverted, the colitis in the rectum actually goes into remission, but there are just some times where it doesn't, or they develop this diversion proctitis with the J pouch. And there you see my little dehydration guy running there. So once the bowel continuity is restored, so now we've closed the ileostomy, the initial bowel movements are going to be frequent or loose and maybe prompt by gas. And this is because right after surgery, they're drinking a little more liquids, trying to get their system back. The bowel is a little more irritable in the beginning, so they have more gas, and that can prompt bowel movements. You tell them to focus on a high-starch foods, salty snacks, crackers, pretzels. Rice Krispie treats work great to help thicken stool as well. Again, I tell them at first not to drink on an empty stomach because once again, if you're having a lot of liquid stool, it's going to be a little more at risk of a leak and they're going to be emptying and have a higher number of bowel movements. So if we can get it thicker, decreases the number of bowel movements and actually would decrease any risk of leak if they were going to have it. I tell them not to eat the biggest meal at night or late. They need to eat before 7 o'clock because if you eat your biggest meal at late, you're going to have to for sure get up in the middle of the night and go to the bathroom. So I tell them try and not eat too late. You can have some snacks, but not a big meal. Keep stools below 10 a day. I don't want these patients going a lot initially until their pouch kind of develops and the size increases over time. They may have a little higher number, but I don't want them going over 10. I want them more down around 5 to 6 bowel movements a day and maybe 1 at night in the beginning. but over time that will most likely diminish. Now, how are we going to do this? They're going to use the antidiarrheal. And I tell them to start before a meal, bedtime. Maximum, I usually tell them, is 8 a day. I tell them, do not read the box, because they all read the box and they're like, what? It says to take it when it's loose or whatever. No, we're going to train the pouch. We're going to train your system, and you're going to take the Imodium before meals and at bedtime and see how that goes. I usually tell them maybe start with 1, and then they can double it as needed. And a lot of times they only need this maybe for the first several months, some of them. Then when the pouch over time is holding more stool, the bowel movements go down, they learn how to eat better. Maybe they don't need it every day eventually. And then they just use it when, hey, I'm going to go on an airplane tonight. I don't want to go to the bathroom, so I'm going to use Imodium. I'm going to go out fishing, where they don't want to go so much, then they'll use the Imodium then. So I have both sets of patients both ways. Some do it routinely and others don't have to over time. Fiber preparations are great. Metamucil. Meta wafers are great. Patients seem to like them. It is a Metamucil preparation, but it's in like a cracker. They like it. Urinary function in the beginning, some of them go, geez, when I pass urine, some stool will go. Well, right after this procedure, those nerves are down there sort of together for urinary and sexual function and with the stool. So in the beginning, the nerves are not fully communicating, and when they urinate, they may go. That will dissipate. That only is maybe the first couple weeks, if that. But I tell them, don't worry about it. That will, as you heal, that'll get better. Sexual function, I see dyspareunia in women. The pain on sexual intercourse, which is often due to adhesions and things that are, it's sort of a little stiffer in the beginning. I tell them over time, as adhesions and scar tissue softens, it will get less painful, but you have to be patient. If it persists, I send them to a pelvic floor therapist. And I've not sent a lot, but a couple people I have, and it does really help. Weak erections in men, for the most part, this also gets better by about a month or so. I give it like 3 months to see if it comes back. If not, then I would send them to a urologist. And the other thing is those performance enhancement drugs do work on these patients too, if it does become a problem. The other thing, don't forget to tell them no anal sex. These patients with a J-pouch cannot have anal sex. Otherwise, they are definitely heading for incontinence. You're stretching that material, the anastomosis and the sphincters, so we tell them no. That area down there is prime real estate. Don't be messing with it. And the other extremely important thing I tell patients, remember, improvement is seen over time. And I'm talking 3, 6, 9, 12 months, 18 months. I can see improvement with these patients. The pouch has to learn. It basically learns how to sort of get larger in size. It learns how the patient's way of eating is. It has to adjust. So I said the pouch adjusts to you and your eating habits. So it takes time. And that's the key thing to tell them, because they often think, oh, the minute they've had that last surgery, things are going to be great. I'm going to be normal again. No. We're going to help you get there, but we're going to see improvement. Bowel movements may decrease in size. If you're going to have a little seepage and it may be a wetness, that may go away in size. The dyspareunia with the women, all these things get better over time. So here's some other things once continuity is restored that I really talk to patients about. If there's stool leakage, like I said, usually goes away over time. They need to use moisture barrier ointments, and I tell them to start using that right away after surgery when their stools are looser. And they need to use it later on when they're eating certain foods that may make them their stools looser. They need to prepare for it. If they're going to go out, and let's say they're going to go drink, and they're going to go have a few beers, like my young kids, like, oh, can I go drink? I'm like, yeah, but the stool may be thinner. So when you're drinking, eat, but also maybe apply the moisture barrier ointment before you go increase in case those stools are more liquidy. The other thing, I like butterfly anal incontinent pads for them to use between their buttocks. It protects the skin. They all think panty liners, hey, it'll protect the skin just if I had a little leak or if I pass gas or something. No, the stuff is sitting between your buttocks. I want you to use the anal incontinent pad. You can use the panty liner, but always remember, it's the skin between the buttocks we want to protect. I tell them to use wet ones instead of toilet paper. They're wiping a little bit more. Toilet paper can be like sandpaper. Wet ones work perfect, and they clean the area well. Acidic foods, bile salt stools often cause a burning discomfort in the anus, and that's where, if they're talking to me about that, I say watch the tomato sauce and things like that is more acidic. Sometimes add sugar to your tomato sauce that helps cut the acidity. But juices that are acidic, etc., they may need a bile salt binder also. Because remember, the terminal ileum is caught up in this J pouch, and it may not be absorbing the bile salts as well. So then I'll give them that, and it does make a difference. I don't find a lot of people will need that, but there are a few who do. And sometimes they only need it in the beginning, and later on they don't need it as much. Initially, they may feel spasms in the pouch, because remember, this pouch is sort of constructed a certain size, and nothing's really been going through there but the mucus. But now they're starting to eat and having stool. This is like a muscle. It stretches, and they can have like pouch spasms in the beginning. This will go away. It just will take a little bit of time. Often, like within the first month, they don't have it. If it persists and it's really problematic for the patient, then I give them an antispasmodic. It's not something they're going to need forever. It's only in the beginning during the first couple of months, maybe with the adjustment phase. And right after surgery, before they come and see me in the post-op clinic, I have them do a 7-day food and stool diary, which I think is very helpful for them to see when they are having bowel movements around the clock. And here's kind of what I give them. I have them kind of document a little bit about what they eat, when they're having stools, and then I have a code about liquid bowel movement, pasty, formed, and then the SM is a minor leak and an SX is a major leak. So I kind of want them to start correlating how they're eating and how it affects their bowel movements, and if they're going to have a leak, what might have caused it. I find that helpful. I also use this because I do follow these patients the first 3 months, every 3 months the first year, and then I may see them in 18 months, and then 2 years. I follow them then yearly. At every one of those visits, I have them complete this, as well as I ask them every pertinent question. Do they have, are they getting leaks, and do they have to use Imodium? All kinds of key stuff. But I find this is kind of the most important in the beginning for them to understand how their food is affecting their bowel movements, how they're eating. And I do have it when I see them on a yearly basis. I like them to do this because sometimes what they think they're doing in a day, when they actually sit down and they have to document it, they find, oh, maybe it is a little higher, or, oh, gee, it isn't that much. Okay. So I find that very key in their management. And here are the supportive treatments I already talked to you about: the antidiarrheals, antispasmodics, bulk formers, bile salt binders, acid-reducing drugs. All my IBD patients, I always tell the house staff and the docs, I want them to be on like Prilosec, omeprazole, whatever, at least for the first month after surgery, only after surgery, because I find that post-operatively they're coming in with feeling a little nauseous, they're burping, and I just don't feel right, and every time I kind of figure out, they didn't go home on their Prilosec or Nexium or whatever. It does make a difference post-op. But as I said, only for 30 days. That's it. Because surgery is a stressor, and just everything they've been on, and if they were on drugs and the steroids and all that, they probably were taking it before. But I find that's a key thing. Otherwise, I'm getting these calls if they're not feeling well and sick. But that's only post-op. Perineal ointments, the moisture barriers, and apply to dry skin. Remember, tell them don't be applying moisture barriers to wet skin, or they will develop an a fungal infection there, and then you got to put them on antifungals. And then I'm checking iron and vitamins and minerals once a year as well. Here is what I tell every patient. You take this, and I want you framing this in your house, and I want you to hang it on your wall. And I want you to look at this so that you never forget where I want you to be, and this is good functional results. 4 to 8 stools per day, best. I want them to get into 4 to 8 most of the time. Liquid to pasty consistency, occasionally formed, some of them will have, but I want them to aim for 80% of the time a thickened stool. And I also use that same concept with patients with a ileostomy, always aiming for 80% thickened stool in a stoma, but also with these patients now with a J pouch as well. I tell them one nocturnal bowel movement can be normal. I find a lot of your younger kids, and they end up not having any at night, or if they do, try and use the Imodium and see if that will prevent that from occurring. They can usually delay a bowel movement, sometimes in the beginning, maybe for a half an hour to an hour, but as this pouch adjusts and it gets larger in size, as they can delay bowel movements, they can go for 4 hours or so. They feel, the little urge to go, but then, they sort of don't pay attention to it, and they do fine, and they can end up holding it, which is good. There's no urgency to pass stool. They should not have that. May or may not be able to pass gas without losing stool. That changes over time as well. I have some that have no issues, and then I have others that they don't even want to try. But I have some that are like, no, Michele, I just have a few little spurts in there, and I just don't want to take the chance. But most of them eventually can. Most have no leakage. As I said, if present, it might be at nighttime, and it's usually only a wetness. This is not an outpouring of a full bowel movement. But it's at nighttime when, we have that basal resting tone with our sphincters, and it doesn't react. And usually it's if they're in a really dead sleep that can happen to some patients. And I may see that a little more with older patients. And as you said here, older patients more at risk for leaks. And if they've had the hand sewn, where I said, remember when you do the hand sewn, we stretch those sphincters, they may be a little more risk in the beginning, but that goes away. Perianal moisture barriers to prevent rash, use that as they need it. They can eventually eat most foods. In the beginning, I want them to sort of, right after surgery, you follow that low residue diet, but after that, start introducing foods and see how it goes. Now, they all say that spicy or high roughage foods may increase their bowel movements. I tell them it's not going to hurt them, but they don't want more bowel movements. So patients say, I want to eat corn. It's summer. I'd like to have some kernel corn. And, well, try it. Moderation is key. And it's going to make you go a little bit more. So they go, you know what? I'm going to do it on a weekend. When I know I'm going to eat things I want to eat, I know it may make me go more. I'll prepare with my moisture barrier ointment or whatever, and I'll be at home when I know I'm going to go. And then after that, okay, I've satisfied my craving. I'm going to go back into my routine, what I know works and is fine. So those really high roughage foods that, we usually tell patients to kind of really stay away from, they can use them, but in moderation. Obviously, if they're going to eat 4 bags of popcorn and 4 things of corn, that may cause some serious little problem with really going to the bathroom a lot, or even make them feel like they might be a little bit obstructed there for a second. But really, they can eat small amounts, and they do. And as I said, most patients will eat anything. And once again, function improves over time. It may hurt them a lot more in the beginning, but later on, they seem to do better. Now, here are the percentage of complications that I see with a J pouch. Pouchitis is the number one. It's around 40 to 50%, I would say, overall. It's just an inflammation in the pouch. Cuffitis, I see that in that little retained rectal area. Anastomotic complications like leak, pelvic sepsis. They can develop a pouch fistula or a sinus tract. Sometimes that could possibly be if they've developed Crohn's. sometimes it could be right after surgery and could really be a mechanical surgical issue where they develop a leak or a sinus tract. Anastomotic strictures, that I see more common with the hand sewn. Dysplasia neoplastic, that can develop, and that could develop in that cuff. So those patients we surveillance every year for sure, because there is a percentage that can develop. Sexual function, 50%, you was always reading in the journals, but I tell you, I think the laparoscopic approach has really affected this, and I really felt we only ever saw 35%, but I think it's even less than that now with the laparoscopic. The men, you see the impotence, decreased erections. Women, again, dyspareunia. The female infertility, actually, like I said, is from, I think, often the adhesions and scar tissue that are blocking on the fallopian tubes. Crohn's disease, 10 to 13%, usually develops later. We feel like somewhere down the road, particularly these indeterminate patients, they could later turn into Crohn's. There's various reasons. We think that IBD is really one disease, and you have one more at one end or the other, but there's so many different phenotypes of each that it sometimes really is hard to definitively say. The pelvic vein thrombosis, that's around 7 to 10%. IBD patients are at a higher risk anyway of DVTs. We know that, so that's always something that we pay attention to, but it really is a small percentage. And they could obviously lose the pouch. It's a potential. Here's where the anastomotic complications could occur, right up here at this tip of the pouch. You could get a leak there. It's going to be on all these suture lines and anastomotic areas. Like here is your ileoanal anastomosis. They could have a leak that could develop a presacral abscess. If there's a sinus tract or a leak, could get a pouch vaginal fistula. So those are the more common places you might see that. Pouchitis, I'm going to talk about a little bit. Most common pouch complication. It really is like an abnormal mucosal immune response. We think that the microbiome is changed in there, and they're more susceptible to pouchitis, and it really is just an imbalance in the intestinal ecosystem. And why, what supports that? Because restoration of the fecal stream, that's when it occurs more or less in the pouch, is when you put the stool back through there. Fecal stasis, if somebody had an anastomotic stricture and they're not emptying out, they're at a high risk of developing pouchitis. And we know it responds to antibiotics. Put them on antibiotics within 12 to 24 hours, their symptoms turn around dramatically. It's that quick. Classic symptoms, watery frequent stools, urgency, that feeling of incomplete emptying, low abdominal pain, cramping down in the pouch area, fatigue, feels like ulcerative colitis again. That's exactly a classic statement that they say. May or may not have blood in the stool. I don't always see that unless it's ulcerations in there, more severe pouchitis. It's been chronic. Fever, same thing. It's more chronic. Leakage of stool, incontinence. Some do have that because there's inflammation obviously in there. Dehydration you may see because they're going so much. And those extraintestinal manifestations, the joint pains or the body aches, that you may also see because with inflammation, it erupts those. 50% of UC patients develop at least about one episode a year. And more recent studies have said that about 80% may develop one episode at 30 years after an ileopouchianal anastomosis. Occurs usually after 6 months. We find that before that, we haven't seen it occur. It usually doesn't occur till then, and which I really pay close attention to because there's an adjustment phase with the pouch. They have a little higher bowel movements, etc. So you don't want, immediately the patient's thinking, oh, I've got looser bowel movements and going more. It must be pouchitis. No, it's probably what did you eat? You have to think about what are you doing? Are you really doing everything to keep the bowel movements, thickened? Even a menstrual cycle, they may have a higher number of bowel movements because they'll think, oh my gosh, I must have pouchitis. So really, I try and investigate that. It usually is not. And in looking at our population, if they haven't gotten it by 2.5 years, they may not get it at all. 60% develop 2 or more episodes. 10 or 19% have chronic or more frequent pouchitis symptoms. And the more chronic it gets, obviously they could be at risk of losing the pouch, and eventually sometimes that could eventually turn into like a Crohn's disease situation. Here are potential risk factors: extensive UC, backwash ileitis, sometimes extraintestinal manifestations, NSAID use. Again, I tell them to stay away from NSAIDs, ibuprofen, Advil, because like with UC, it can also bring on ulcerations. Now, a sporadic NSAID I use for one day may not, but if they're using it on a continual basis for things or been in an accident, long-term use could do that. Being a non-smoker is questionable, but it's been mentioned. Younger age at time of proctolectomy just means the length of the follow-up, and then some of these genetic polymorphisms. How do we diagnose it? Symptoms, obviously, usually present, but doesn't always mean it's pouchitis. Maybe they could have C. diff, or maybe it's because of what they ate, or like I said, with the menstrual cycle, they're going a little bit more. Maybe they got a virus. They can get a virus as well, so you need to investigate those things. Pouchoscopy is the best, and taking biopsies, and you can also detect with the biopsies if it's Crohn's disease, and always the scope should go above the pouch into the small bowel as well, because that is where a lot of times the Crohn's can be detected as well. Like I said, the biopsy, definitely do the anal cuff, because we're going to biopsy that to rule out any dysplasia or anything, or anusitis. Fecal calprotectin can be used as well. I use that in between time if I think that perhaps a patient may have developed pouchitis. Instead of doing a scope, I do that. Here's sort of the pouch disease index. You probably have all seen that with the PDAI score and what they're looking for here. Here's the fecal calprotectin, and they've noticed that sometimes it can predict pouchitis within 2 months before it's even occurring. You're starting to see elevated levels. So that kind of tells you it could be a silent disease too, like ulcerative colitis. So interesting, but there's always research going on that, and I feel like it could be silent too in there. Here's what a normal pouch looks like, and I assume you guys are going to get these slides so you can look at them later, but this points to exactly what the area looks like. And here you saw, this is called like the owl's eye, and that's in the pouch body. And you see where you're seeing the 2 chambers there. And this is normal ileal pouch, nice vascularity. Here, different phases of pouchitis. You see the ulcerations in there, a whole lot of different phases. C. diff pouchitis, I said that's something that you kind of have to look for. I'd say if somebody had it before and had a higher risk of it, you could see it in these patients, only about 10%. But usually higher stool frequency, weight loss, and a positive test. Here's some of the risk factors for that as well. Pouchitis treatment. Here's acute chronic, usually with the antibiotics. Definitely a 2-week course, and really have to explain to the patients, you got to take it the full 2 weeks, even though you may feel better. Budesonide rectal enemas if the antibiotics aren't working, and these are the 2 most common ones I use. Chronic pouchitis, I usually extend the time frame, give them a probiotic. The VSL number 3, double strength, is the one that really has been researched to work. I do use that. Some patients do and others don't. Some say they just may think it makes things go a little bit better if they've had a lot of issues with gas or things. And some of the patients, they seem to do okay. So I do use that. It's very expensive, and not everybody has the money to do that. The vedolizumab, that's a current study for that's out there now that we will be looking at using for chronic pouchitis to see if that will work. Obviously, acute pouchitis, a chronic pouchitis, it's the length of time. Probiotics, a little more. I'm not going to go into full detail here because I see my time is, I'm already past. But again, the VSL number 3 and the dosing of it, and it needs to be the double strength. Cufitis, as we talked about, that's actually ulcerative colitis in that cuff with the anal bleeding, severe urgency, and tenesmus. That's how you know it's cuffitis. That's severe tenesmus there in the blood. Treat it the same way we do some of the colitis things. Here's the stenosis. I always do a digital exam on all these patients to make sure that stenosis, if it's right there at the anal area, I can dilate it with a finger. It can get down to a point where you can't get a finger in, and then I got to send them to an exam under anesthesia with anal dilation. And then I bring them back maybe early, like in 2 months or 3 months to make sure it doesn't narrow down. Stenosis proximal to the pouch, that can occur. That gets a little bit concerning because why is it narrowing up there? Could that potentially be Crohn's disease because we're above the pouch now? And sometimes they can do that with balloon dilations. But once again, that's a little worrisome for maybe Crohn's up there. Here's the Pouchitis Treatment. Algorithms, we all love algorithms now. And so this is out here, and I particularly am more focused over here, what I've been telling you with the pouchitis, but over here are evacuation disorders and all kinds of things like that, which is a real nice one. Sexual function, just ask. That's all I say. That every visit I ask them about sexual function, and I talk about it. The dyspareunia, like I said, I'll send them to pelvic floor people. Before sex, make sure you empty the pouch out because some of them are fearing they're going to release stool. And male impotence or decreased erections, I give it time, send them to urologist if necessary, but performance enhancement drugs do work. And again, psychosocial, most important, always be asking them every visit about their quality of life. These patients often have depression, anxiety, and post-traumatic stress disorder. They've had a long life with this disease. They've been hospitalized. It's been traumatic to them. And I find particularly my young kids all have some type of issue. So I am sending them to behavioral therapists, whenever I assess these issues and concerns because they are real. And bottom line is we got to ask because they aren't always going to bring it up. And this takes more time during visits, obviously, when you're assessing all these kinds of things. So very key. Quality of life, between the J-pouch and the stoma, to be honest, both populations are very happy. Patients with a stoma, most all of them are happy. My J-pouch patients are happy too. So either way, the quality of life is good. Here's my follow-up initial phase. That's the adjustment phase. Follow them every 3 months the first year, and then 18 or 24 months, but then yearly, doing all my assessments. Pouchoscopy every year, or earlier if they develop what I think is pouchitis and we really got to look in. But I'll use the fecal calprotectin if I'm not sure. And then here's the assessment. Bowel movements, leakage of stool, perianal skin integrity, ileoanal anastomosis, do that digital exam, quality of life, sexual function, and meds, review what they're on. This is every assessment with a J-pouch. Remember, with an ileoanal pouch, they can always go back to a permanent. But if they have a permanent, they can't go the other way. Sometimes patients say, oh, I had this done. Do you think I could go back? No. So, but remember, they can always go back. And here's the take-home points. Key, really, function improves over time. Don't ever forget that. And here is my surveillance pouch of how often I surveillance them. But always yearly, pouch, depending if they're high risk for developing the cancer in that ATZ, then I will send them more frequently. But if they're not, maybe every 3 years for the actual pouchoscopy, unless they've had pouchitis or cuffitis or something, then I need to check. All right, sorry, you guys. Here is the ostomy core curriculum. I have a chapter in there that really goes over a lot of this stuff. And here's a patient sends me. This is from a Capri Sun. I always had patients sending me things. Respect the pouch. And there was the more newer upgraded version of the Capri Sun. The power is in the pouch. And so here's mine. Respect that pouch. And here's my team right in your face. All right. Sorry, guys. I went a little long.
Thank you, Michele. That was excellent. And thank you particularly for those clinical pearls that nurses appreciate so much in the clinical practice. We do have about 5 questions. And I'll take the first one from Karen at Sick Children's Hospital in Toronto. What time frame would you suggest in stopping prednisone and biologic therapy prior to the pouch procedure?
So when you look at that, so those patients that are going to be on steroids and on biologics, we're going to do the colectomy on them. So we're not going to have to worry because we're going to stage those patients out. And they don't have to stop. We want them on the lowest dose of prednisone. We don't want them flaring when they come to surgery. So you want them on the lowest dose of prednisone they can get. And as far as the biologics, unless it's like the week, before or whatever, but those are the patients we do the colectomy first. We're not going right to the J pouch. We're just taking that colon out, and then they get off everything after surgery. They get tapered down off the steroids, etc. So we're not worried. We're not going to do a J pouch as the first surgery. We're going to do the colectomy as the first surgery. And no, they do not have to be on. You want them stable when they're coming to the colectomy.
Thank you. The next question is from Usha from McMaster in Hamilton. Can women get pregnant after a pouch procedure?
When is what?
Can women get pregnant after having the pouch procedure?
Oh, yes. Yes, they can. We advise them, though, to wait maybe at least 6 months to a year if they can. But absolutely they can get pregnant. I told you what some of the potential risks were, but again, I think when we do this laparoscopically, that risk goes down. But you kind of want the patient to really recover from surgery, so we advise them not, at least wait 6 months. Now, we've had a patient get pregnant at around 3 months, and it went okay, but the patient really needs to recover after surgery, sort of learn how to live, doing all the things and finding out what their best pouch function can be. So I prefer they wait, but they don't have to. The main thing we tell them, though, is we prefer that they have a C-section versus a vaginal delivery. And the reason being, if they would need an episiotomy, once again, I said that's prime real estate down there. You start cutting and they cut those sphincters, that's bad news for incontinence. So any high-risk patient or any J-pouch patient, I think they need to see a little higher risk OB. But then again, we've had patients who have delivered vaginally because it just happened like that. They did okay, but you don't want them to have an episiotomy.
Thank you. The next question is, you talked about fecal calprotectin. Is there a specific reference range you're using for patients with pouchitis?
Yeah, I think you guys get my PowerPoint. If you go in there, it's greater than 59 on up. I see it at different levels. I had one today was 150 that came back today on a patient. So it's greater than 59.
Excellent.
And then you have to think, greater than 59, is there something else going on? Is there some other infection there? Is it really pouchitis or could it be something else? But that's usually what I use, and it's obviously less invasive.
Thank you, Michele. We're getting notes of appreciation for the super amazing talk, and you have to come to Toronto in person one day. The next question will be, do you involve psychologists in the pre or post-operative stages?
Hopefully a lot of times our GI guys are a little bit on top of that. But I do, when I talk to these patients preoperatively, I bring it up right away. Some of them are already, have issues and they're seeing someone. But I talked to them, I said, do you have a therapist? Let's, let's look at this and let's try and find you someone, because I said this will really come to light even more afterwards. And some of them do, but if not, I get them connected right away. And that's the other piece. That's why I see them so frequently. I really want to keep a handle on how they're doing. And these young kids, I had one that was almost going to go commit suicide. And, it's like I happened to call him, and he was in a bad state at the time, and, talked him through it and got him into some therapy. But surprisingly, the post-traumatic stress disorder thing, that is huge as well, because these patients, even coming to visit us, they feel like, they came there so many times and they're reliving coming back in the hospitalization. And if anything happened negative at the hospitalization, that just sticks in their head. Or if they really got sick or had some bad complication, then coming back all the time, they're like, they're kind of crazed, that they don't want to come. They don't the minute they get out of their car and they're coming up in the elevator, they're like almost freaking out. So I have my list of referrals. We're a major institution in Chicago, and we get people from all over in the suburbs. So they don't always want to come back here. So we have connected with behavioral therapists and psychotherapists out in the communities to try and get them help as well and refer them. And I would say for the most part, they do follow through and do it.
Thank you, Michele. The questions are pouring in. The next one is from Barbara out of East Coast from Halifax. How do you cycle your antibiotics for chronic pouchitis?
So for chronic pouchitis, if the 2 weeks obviously didn't work and it comes back within a week or two, because that's usually what it does when it's chronic. I mean, they could get it 3 or 4 months down the road, but I don't think that's chronic. It's when it comes back within a week to 2 weeks after they've stopped that antibiotic course. Then I will put them on a month of antibiotic and try and get them off after that. If not, then I put them on 2, Cipro and Flagyl. Those are the 2 that I most like. And keep them on that and then try and get them off. If I can't, and it totally persists and they have symptoms, and they start getting symptoms with the antibiotic, then I send them over, because then we got to look at possibly budesonide, or we go into looking at, which I think now vedolizumab would be a potential option if we can't get them off. I have some that are on it, and they may be on 1 tablet of Cipro every couple days or whatever, and it seems to keep them at bay. I also think the VSL number 3 double strength, believe it or not, may keep it at bay, because I do notice in my patients, once they get pouchitis, I stick them on that, and I want them to do it twice a day for a year and then go to once a day. Sometimes when we go in and we do the pouchoscopy, the pouchitis is really mild, and it kind of persists that way. So I'm not sure if maybe even the VSL-3 may help with that.
Thank you,
and
Michele.
The Flagyl, they don't always tolerate that for a long period of time, so I tend to go with the Cipro. Xifaxan is another one, but patients, that's way too expensive, they feel. And sometimes I think the Cipro works the best if it's going to do it.
Thank you. The next question is, are you following with routine fecal calprotectins? Is there a specific schedule you're following every year or every 6 months, or only upon symptoms of pouchitis?
I really just kind of do that if I see there's symptoms or I'm questioning something. I do the pouchoscopy every year, pretty much, unless they've had a couple scopes that they've all been normal, then maybe I'll go out to 2 years or 3 years. But the fecal calprotectin, I'll do that if I'm suspecting something right off to get a level. And basically just when I'm concerned about it, Now, I just did this one on this patient that I was telling you about today. I will probably recheck that maybe in a month or two and check the fecal calprotectin that way and see, has it dropped now that I've got him on antibiotics?
Thank you, Michele. We're last 2 questions left. When do you start agents such as cholestyramine, a bile acid suppressant postoperatively? Do you have a certain amount of time that you allow for the surgery, between surgery and bile acid suppressants?
Yeah. So I don't start it unless they are telling me that they have this awful burning pain down there in the anal area when they eat. And I would start that as soon as when they're telling me that and it's persisting. You know, usually I'll talk to them first and say, okay, like, what are you eating? What do you think is causing the burning? Or is that burning more because you're going so much? If you're going 10 times, we got to get that down. Remember, I want you to go down around 6 more. If we get the bowel movements down, we get them thicker, maybe they won't have that burning. So I kind of assess that piece. And if that doesn't work and that burning is persisting in that anal area, then I just start it. And I keep them on it for a month or so and see if that's okay. And then often they just kind of stop it themselves. And then if they get the pain back again right after they stopped it, then they'll go back on it. I don't have anybody that stays on it for a long period of time. It's mostly in the beginning. I think in that adjustment phase when they're having that burning pain down there.
Thank you, Michele. And also just for the audience, when you're suggesting cholestyramine, make sure that the timing with other medications is confirmed with the pharmacist because it affects absorption.
Absolutely.
Sorry, Michele, go ahead.
No, I said absolutely. Thank you.
You're welcome. The next question is mucus fistula infection. How do you look for and what is the treatment?
For a mucus fistula infection? A mucus fistula. So when are we giving them a mucus fistula? They're not thinking about the loop ileostomy, are they? I guess I want to ask. We don't really do, where they have a mucus fistula that often.
Yes.
I want to ask, what are they talking about there?
And the loop ileostomy.
The loop ileostomy?
Yes.
So an infection around there, I still am not quite sure what they're talking about with the mucus fistula, unless they're talking, I guess I'm kind of confused there. With that loop ileostomy, there's, the infection that can occur around the skin, and they get mucocutaneous separation around there, which will heal over time. Or are they talking about the diversion proctitis in that lower loop with the J pouch? I'm sorry, I'm confused on that.
She said the first one you said. We do have
the loop ileostomy.
Have loop ileostomies or colostomies, then they'll have a mucus fistula. If they have a loop ileostomy or colostomy, then a mucus fistula is not needed. But Karen, I don't know if you want to be more specific about your question.
Well, we don't really do mucus fistula type things. We always do the loop ileostomy on these patients because that's what makes the takedown so easy and simple. We seriously don't do a mucus separate by itself. But if they get an infection in that diverted loop of bowel, we treat that with Cipro. Like if they're having a lot of mucus discharge from down there or whatever, we do treat that with Cipro. or you could use like a Euceris foam or an enema.
I don't see any further comments. So, Karen, unless you have anything else to add.
She should email me.
She said
we can figure it out that way, what she's talking about.
She said you answered it. And the last question, you showed in one of your slides. Do you use a specific one, or are you recommending a specific stool chart for monitoring, documentation, or patient education?
So I definitely have like the 3-step, like in my slide deck. You're welcome to use any of those, by the way. I use that 3-step one often, and we do have like a little hand, it's like a fold over that we, educational tool that we use. The stool diary there, that actually I have them all sheets that I give the patients. Now, some of them are, these young kids are so good with using, apps on their phone that they come to me with their diary on their app, and they keep track of it that way. But I have a whole packet that assesses function with questions, and it asks them everything that I would want to know. Like I showed that one diagram up there with, here is exactly what I assess at every visit. I have all those questions in a questionnaire that I ask the patients and have them bring to me at every visit. So I kind of assess all the key things each time.
Thank you, Michele. This concludes the questions. Do you have any final comments?
For me or them?
No, for you.
Well,
there are no more questions coming in. Unless somebody else has any further questions, we'll conclude the session here. But if you have anything else to add, Michele, thank you so much for your time, and thank you all for participating tonight. Emily from Crohn's Colitis Canada had confirmed that you will be receiving the slide deck for tonight's presentation. Thank you so much, Michele. We truly appreciate your presentation tonight.
Well, I thank you so much for inviting me. And like I said, these patients really need to be followed, because if they are not followed, what I find is they fall into that ulcerative colitis way of thinking, where they settle for symptoms when they have higher bowel movements or things aren't going quite right. And these things creep up on them. Over time, they're going 15 times and they're not thinking. They start settling. Oh, this is kind of how it was. That's how it was with the colitis. That's how this is. No, it's not. And that's why I follow them, because I keep them on track and don't let them fall into and just settling for their symptoms.
Thank you, Michele. Thank you all. Thank you, Emily, for supporting this. And once again, thanks Crohn's Colitis Canada, CANIBD, and Takeda for the generous support tonight. Thank you all, and have a good night.
Thank you, everyone. Good night.